Welcome everyone to our June webinar at the Federation of Medical Women of Canada. We've used the remote distancing and pandemic as an opportunity to provide a series of unaccredited webinars for our members, particularly on wellness and well-being. Today we welcome Drs. Andrea Lum, and Laura Foxcroft from the Schulich School of Medicine in London, Ontario. They're longtime members of our federation from the London area. I'm going to be turning it over to them shortly, but I just want to thank everyone for giving up some time to join us today, and to thank Drs. Lum and Foxcroft for volunteering to give this presentation. This session is going to be recorded and will be accessible from our website likely this afternoon or early next week. So without further ado, if Drs. Lum and Foxcroft could unmute themselves and begin the presentation, and we will have a Q&A afterwards. We've got a few questions that were submitted in advance that I'll be asking, and then we'll open the floor up to general questions. Thank you.
Thank you, Michael, and thank you for the Federation of Medical Women for inviting us today. Laura and I are very excited to present to you. We'll give you back a little bit of time at the end for sure to ask questions. And we're going to talk today about our program, which we launched during COVID. We're now in COVID wave 3. Hopefully there are no more waves, and happy to share our experience. Laura Foxcroft and I are decanal leaders at the Schulich School of Medicine and Dentistry at Western Ontario. We do receive a stipend for our decanal roles. We do not have any commercial conflicts of interest. What we hope you will learn today is for you to understand our program, how we developed our program and implemented our Peers for Peers program. You would be able to describe our components, which may be different than any program you might be thinking of, but also to be able to customize from our experience. And you can also see if the program is of value for yourselves or your department or your practice. So when we started during COVID 1.0, literally within the first week of COVID, we rapidly realized that faculty well-being is and will be impacted. Little did we know at that point in time how long we would be in the COVID experience. And today on June 11th, if you're in Ontario, we're getting our first hint of a slight relief. It's been a long year and a half. The vision is very simple. It's not complex. We felt that faculty well-being matters to us and every single one of us. And if we wanted to help ourselves, we needed to develop a program so that we could do it ourselves. Simultaneously and almost fortuitously, we knew that faculty burnout and physician burnout has been an underlying theme across Canada and the world. So we had already started in looking at what our current experience was at Schulich at the time. So in pre-COVID times, January 2020, when we knew nothing about COVID, we had already implemented through our medical advisory committee a survey. We utilized the Ontario Hospital Association survey tool, and we asked a series of questions. What was really telling is the fact that 50% of our physicians, our faculty, indicated they were either burnt out or strongly agreed that they were burnt out. And 30% indicated they were anxious at work. During COVID, we had a survey that came through the hospital as well, but this is a hospital survey that included both staff and physicians. And in that survey, they asked about what strategies do you use to enhance your resilience at work? And it was interesting to note that 75% responded that speaking to a colleague was the most useful for them. So at the time that we started this, I use a formula or a change management process that is from Mary Lippitt back in the 1980s. And it looks at vision, incentive, skills, resources, and an action plan. And at the end, I'm going to refer back to that in terms of how we introduced a new program, implemented the program, and continue to manage the program as we go forward. So what did we do to start off with? As the Vice Dean of Clinical Faculty Affairs, when I started in January 2020, so as a bit of an aside, we have a brand new team. I started in 2020. We have an Assistant Dean of Professional Affairs. He started also in 2020 in March, April. Laura joined us in October. So we had not only a brand new team, but we were introducing new programs. What we needed at the beginning is a steering committee, like all things. And I leaned very heavily on the other decanal leaders within Schulich to start up, because I really myself in January had nobody within my own portfolio. We very rapidly ramped up and we started with 17 well-being leads. Schulich supports 2,500 faculty across our continuum from Southwestern Ontario, with the largest cohort of faculty, around 900 faculty at our London bases. As you know, you can't introduce anything or adopt anything without an incentive. We all know as physicians that health and well-being are very tightly linked to quality and safe patient care. So the reasons for doing this is really not terribly obscure. They're very simple. What I would say is that as a past chair of the Medical Advisory Committee at LHSC and had just finished my term there in 2019, I had a chance meeting with one of the facilitators of the Air Canada peer support program. So the pilots have had peer support for many years. In fact, he was about to invite me to one of their training boot camps, and they hold this across the country for their pilots. Nevertheless, it was not to be because of COVID, and we never did have time. But he was so kind to share with me the basis of their program, which is in part how we managed to get started so quickly. You also know that the Canadian Patient Safety Institute has toolkits on their website that can help any institution or any hospital start up a program for themselves. So we also used a bit of their toolkit mapping. There is a lot of literature, as some of you probably have attended Jo Shapiro's talk when she presented in Canada in 2019. The 2020 conference was canceled on physician health, and that was led through the CMA. We did not need to do another study. We had enough studies, but we truly wanted to put something in place that would be meaningful for our faculty. So what exactly is our Peers for Peers program? There are 4 key components. The first one, which is very important, is that the members who are providing the well-being support and those who seek support need to be reassured that there is psychological safety for themselves. So our peer supporters are not titled leaders. We absolutely want them to be engaged and interested in being a peer supporter, but they needed some distance from their department chairs or anybody in their own team who would be considered their evaluators. The outreach is confidential and invitational. So we promoted our program once we had the components of it through internet, through our email messaging, and through the departmental chairs. Schulich has 14 clinical chairs, 14 departments, and we truly leaned upon our leaders to help our program get started. The first part of the program is really based on training our well-being leads. So as we developed the program, we also simultaneously, in a parallel fashion, developed a training curriculum. So it might sound a little bit chaotic, but we were up and running within 2 weeks, and then we continued to train as we recruited individuals into our program. Initially, as you may recall, back in March, none of us had any comfort level with Zoom meetings or WebEx meetings. The whole virtual world was quite foreign to us. In fact, at Schulich, we used to have to drive 45 minutes from one site to get up to the university. And if we can think of anything that COVID might have changed or is a blessing, it has now enabled us to be very comfortable with Zoom platforms. So we ventured into that realm and we started training on Zoom. Whenever you launch a new program, as all of you know, the leaders have to have some basic skills as well. And whatever the program is, you need to have skill training. The importance of having a network and having a steering committee to help also has to be stressed, because on the front end, you will have your program. On the back end, you will need your leaders as well as those resources to ensure that things are well supported. So one of the first things we did was to have a generic email that we have our portfolio coordinators monitor. And that's simply, as you can see up here, faculty.wellbeing@schulich.uw.ca. This is a peer support program. It is not a crisis management program. So the email is monitored during working hours. However, you can also see we have all our well-being leads and their direct contacts posted also on our website, as well as having this generic email. So sometimes, of course, things happen after hours and people need to access us a little bit more expeditiously. So what exactly is our program? What we do is, it is a program where peer supporters listen, provide support, and if additional resources are required, they have been trained and understand where those resources lie and are able to refer. It is based on empathetic listening because as we are all peers, we do share common experiences. We asked for each department to provide a peer well-being lead, and it was a little combination of having the clinical chairs select individuals as well as have individuals come forward. So different departments did it slightly differently, but ultimately the core group needed to be absolutely passionate about doing this work. The peer well-being leads are not paid for this, just like the pilots. They're peer supporters. They do this because they care for their faculty peer. And once we have them trained, then we continue to roll out additional sessions. The first few training sessions were on empathetic listening. What it is not. Peer well-being leads do not provide therapy or give advice. They do not instruct what to do, and they do not diagnose. This is really a bit counterintuitive for physicians. As physicians, we are actually trained to make a diagnosis, to provide therapy, and in some manner, provide the next steps to give advice. And so for some of the specialties, people didn't have any training, and you'll hear from Laura Foxcroft. I'm a radiologist, so this is very foreign to me. And I will tell you, I am not trained. I'm the leader of this program, but I'm not on the ground. But I do understand what is absolutely required. Laura, on the other hand, is an expert. She's an emergency physician, and she does this in her sleep. So we had some very key members who had all that expertise to help us with the program. It is very important to understand as we launch this program during the pandemic, that we can't fix the pandemic, we cannot fix the challenges, but we can also take those concerns back and move them up to various levels of leadership, let them know the concerns, and we'll talk about that as well. And as you recall, PPE was a major concern during wave 1. I alluded to resources, and we truly are blessed when we started this, because at Schulich and Western, we did have a lot of resources on the back end. Not that everybody knew about those resources, but we did have them. And it was also important that everybody who volunteered to be a well-being lead and participated in the program received the same training. Just as I'm a radiologist, I can interpret CTs. I'm really probably not that facile in doing a cardiac arrest anymore. And if I were to do that, I would need additional training or retraining. We also very quickly realized that the team that we have once trained needed to be sustained, and we needed to provide support for our team. So we leveraged the technology we had at the time, and we had a few members who knew very much how to use Microsoft Teams. Both the university and the hospitals were introducing this as a new platform. We chose the university platform, which is a little confusing. Most of our physicians use their LHSC and St. Joseph's email, but we also span across the continuum from Windsor, Sarnia to London and beyond. So we chose to use a university platform because we provide our support for everybody. We needed to update our website, and that's still a works in progress, in order to ensure that our resources are communicated to everyone. So what did we do? In the short term, the first thing, the very key first thing we needed to do was to train people in the various components of conversation. That might sound a little bit counterintuitive as well. However, these are different conversations. We then started with the training curriculum in the medium term and added simulation workshops. Ultimately, at Schulich Clinical Faculty Affairs, this will all form part of Schulich faculty experience. So let me show you what I mean by a curriculum. We were really fortunate to have our CPD on site to help us, our CPD office, on site to help us get this Royal College accredited. You might wonder why we didn't get this accredited through the Family College of Physicians. The Royal College had an expedited process during COVID. And so as you can imagine, we were developing and accrediting at the same time. And so that is why we use the Royal College. We also understand that the Family Practice College allows a certain number of credits to be done through the Royal College. We ended up with 7 sessions. As you can see, the first 3 are concentrated on the conversation, recognizing mental health distress, and we leveraged our peers in psychiatry to help us with these sessions. And then simulation workshops. Although in medicine, we do have experience in simulation, how could we do this in a virtual forum when we were in lockdown? Our university had some simulation experts to help us with this. And we very quickly then adopted simulation workshops as part of our training. And today, Laura will talk about our version 2.0 in terms of all of our resources, how we have leveraged a 2-part curriculum training using simulation, as well as actual quote unquote live virtual workshops. As many of you know, sometimes we do not bring our best selves to work, and professional behavior is an important component that sometimes manifests during the workplace. Unconscious bias, equity, and diversity were also key things for individuals to fully understand, as well as more explicit things like harassment and intimidation. You might be curious as to why we put down ethical framework. During the initial COVID closure, Those decisions were really made through the province and at the hospital level, the organizational level. And it was important for individuals to understand how things came to pass. But more challenging still is when things are being opened up. How does someone determine if a wait list is now growing? How are you going to make those ethical decisions? So it's very important for people to understand an ethical framework. I'm going to quickly go through the components of a support conversation and empathetic listening. What do you do if someone contacts you? Again, very simple, but so you're now a well-being lead and someone sent you an email or a text. And the first thing to do is not to panic. And so we needed people to understand how to go about organizing the conversation, how to invite their peers, how to start the conversation. Listening is a huge component. How to reflect, how to reframe, what are the words that you need to use, and also how to manage yourself, how to breathe in between, and helping the individual make sense of what they're saying, not making a diagnosis, not making an interpretation, but helping them figure out what it is that they're stressed about. And then taking a look with them about how they cope and closing. And at the end, if there is a need for referral or a second conversation, then those would be the next steps. So what we emphasized again and again was empathetic listening, recommending the resources that we would provide them, and then if they needed professional help. What is the professional help? The next steps is really coming through to our office. And it was important for people to understand that just listening made a big difference. We also, during the first few months in COVID-1, realized that our peer supporters themselves, they were new, they needed support in terms of how they were doing. They needed support in terms of their own feedback and their concerns and their questions. And we had opportunities, and this was then led by Laura as she came on board, firstly as a well-being lead for the Department of Medicine. And she'll talk about her experience and how she expanded the department, because some of you will wonder, we had one lead per department, and how did we manage with big divisions? And how did we support the divisional members? Okay. I'm going to stop now, and I'm going to turn it over to Laura to talk about our new training platform. And then Laura's going to share with you some of the results of our program, because you're all going to ask, what was the outcome? Does this really work? Laura, over to you.
Thanks, Andrea, and thank you for having us speak today. As Andrea said, I'm an adult emergency medicine physician and have had an interest in faculty well-being for quite some time. I was the Department of Medicine well-being lead, and in the Department of Medicine, that includes 14 divisions. It's a very large department. There is about 300, almost 300 faculty in our department. So when I took on the well-being lead in COVID 1.0, it was a lot of people to support. It was in departments that were under a lot of stress, like respirology, internal medicine, emergency medicine. So what I ended up doing in my own Department of Medicine was creating a framework with division leads. So I selected leads in my 14 divisions and brought them on board to support the peers in their divisions. What that created, because all of our department leads were now trained by the format that Andrea said, where we all met together on Zoom over the summer. But as I was bringing on new leads in the new departments or divisions, it became apparent that we needed another training platform, one that we could access easily as we brought on new leads, to ensure that they weren't being thrown into a situation that they weren't properly trained for. So what we were able to develop was a new training platform in an online asynchronous format using our local experts and the 7 training sessions that were initially developed. And based on feedback from our leads, we were able to move those sessions into an asynchronous training format online. As we onboarded the new leads, they are able to take these training sessions and then become fully trained for their new responsibilities. That training platform is currently being expanded to be available to other sites outside of Schulich and Western that are wanting to create their own peer support program. Next slide, Andrea. So part of that training program when I took that on was to then support the leads and to meet monthly with our well-being leads, and those monthly sessions were really important. All of our leads would meet in a Zoom format, so there would often be 15 or 20 people on a Zoom, and we would just go over what was going on in everybody's department, who was struggling, who was having successes, and really it was a time to bring the leads together in a format where they could share how they were doing themselves as a peer supporter, as well as how their departments were doing. That's something that we've continued over the year, meeting monthly to check in. The other thing that we were able to do was to create a simulation monthly by engaging our colleagues in psychiatry format, and our peer supporters one person would be a peer in distress and one would be a peer that would be interviewing the peer in distress as a peer supporter, and our psychiatry colleagues were able to give real-time feedback on how to improve their empathetic listening skills. As Andrea said, it was not intuitive for physicians to just listen and not give advice and try to fix the problems, and really our psychiatry colleagues were able to help us with that. Those simulation sessions were very helpful, and we have implemented that into our online asynchronous training platform by having simulation sessions for people to watch. Because during those sessions, even the people that weren't actively participating or doing them, they were just watching the process take place, found that learning opportunity was really quite helpful.
So at this point, sorry, I am going to just go back one slide. I'm just going to highlight how we started this and how quickly we went from framework to program launch. We started on March 23rd and we launched on April the 9th. And within a 2-week period, we went through having our clinical chairs select well-being leads. We went through our usual committee process in endorsement of the program. And then we had to provide information to our joint medical advisory committee. What we did was we leveraged the needs assessment we already had. And as Laura has clearly enunciated, we built and trained our team. What we have also learned is that a small percentage of the individuals we see needed to have secondary resources. And we moved those individuals into our office, and sometimes they will need referrals to psychologists, to psychiatrists, to counselors, coaches, and sometimes at their own choice, they can be referred onwards externally through the OMA or other agencies. Western will provide backup resources as part of our clinical academic program. So after wave 1, we surveyed our well-being leads. As you understand and recall, psychological safety is very important. And individuals are very hesitant in sharing their own personal experience. So by surveying our well-being leads with anonymized events that are not identified or tracked back to an individual, we managed to understand how our program worked Was it successful? And get some survey demographics for our program. Laura, over to you.
So in wave one, what we noticed was that people were reaching out quite a lot. Actually, it was a lot of acute stress. There was a lot of things that were unknown. PPE was a big stress at our institution, as it was nationally. The homeschooling was a big stress, specifically for the physician moms in the group. There was financial stresses, particularly for our surgical colleagues whose ORs were being canceled. Lots of things going on, and people were reaching out to our well-being leads. What we found when they reached out was that one or two conversations with a well-being lead was actually quite meaningful. Similar to the pilots who could relate to pilots, physicians were relating to the acute stresses of physicians. And after one or two sessions of empathetic listening, 80% of the people that reached out did not require any further referrals to outside resources. The 20% that did require referrals, we were able to get them the help in a way that was quick, that was confidentially, that was quite meaningful to them. Wave 1 and 2 were a little bit different. In wave 2, as everyone found, physicians were exhausted. They were very tired. There was still a lot of unknowns. The stresses were a bit different. There was now a vaccine, and the vaccine program was being rolled out, but not everybody was getting a vaccine, and there was a lot of acute stresses associated with that. Our physicians were more withdrawn at that time and were not reaching out to the peer supporters. When we were having our monthly check-ins, this became apparent that all the peer supporters were saying that this was not happening, and we took a new approach with our program. We trained our peer supporters in reaching out to faculty instead of waiting for them to reach in. So we were doing check-ins, just simply asking, are you okay? We never had a negative interaction happen when faculty reached out and asked their colleagues, are you okay? But we did have a lot of people really appreciate the reach out and continue to have really meaningful conversations with their peer supporters. Our peer supporters would offer to meet again, and same results in the second wave as the first wave. 80% of the people that responded really found that the interaction with the peer supporter was meaningful, helped them deal with the acute stress, and didn't require any other resources. There was still people that did require outside resources, and those people were given the resources that they needed. I think that's what this data is reflecting, is just the fact that the meaningful conversation was happening with the peer supporter. The peer supporter really understood the unique stresses of the second wave, which again, similar to the first wave, there was homeschool, there was childcare issues, there was financial stresses, mental health concerns, and vaccine stress was a big stress in the second wave. Certainly, difference in gender was noted. Women were reaching out more than what our male colleagues were, and were certainly under significant stress attributed to just balancing multiple different roles in their life, of still trying to be physician, mom, teacher, life coordinator, and the female faculty in our group really were leaning on the support of peer supporters. But having said that, lots of men were reaching out as well.
Oh, sorry, this previous. So a lot of individuals did send us emails. Sometimes they sent us texts that we have helped, and what they all expressed, every single one of them, was taking the time to have that conversation was really so important to everyone. We have now discovered with COVID-3, and as you all realize, Laura and I come from London, Ontario, and there has been a very tragic event and episode that happened last Sunday. We are so thankful we have this program, because as our clinical peers were caring for the victims in our own hospital, we were reaching out to them to offer support. And I really don't know what we would have done without having our program in place. For those individuals that we received in our decanal roles, it was less than 10% of the individuals that came through. And we were able to restore individuals back to their clinical role within several months. Laura, over to you about our next steps and your executive committee.
Yeah. So next steps are exciting. As Andrea says, we have lots of talent here at Schulich, people that are very interested in faculty well-being, and we were able to create a Schulich Wellbeing Executive Committee in December with 5 people that were actually quite passionate about faculty well-being, and our committee meets monthly. We were able to do an inventory of the programs and resources that exist at Schulich and be able to target areas that we feel are of great need. One of the areas was women in medicine. Another area was our surgical colleagues, and our surgery lead, Dr. Leslie Scott, is a pediatric surgeon here and was really able to expand our peer support program for our surgeons at Schulich quite quickly. We now have 12 well-being leads in the Department of Surgery, so certainly a really important initiative, and that came from our Wellbeing Executive Committee. We, through that committee, revamped the training program. As I said, that committee helped us to really look at the feedback from the first training program and make it better and get it to the asynchronous online format. We've had lots of people reaching out about our program, and we're hoping that asynchronous training format will be something that's useful for other institutions as they start to develop their peer support programs as well.
So Laura and I have taken you through how we developed our program, starting with vision, incentive, skills, resources, and an action plan. And we are happy to take any questions or comments, as we thank you for inviting us to share with you today.
Thank you, Dr. Lum and Foxcroft. Did have a number of people submit questions in advance. I see some of them are on the calls, so I'm just going to call them one at a time. And if they, now some of these were submitted days ago, so they may not remember, but I will volunteer our president, Dr. Carissa Patricelli, to ask the first question.
Are they still all on mute?
I think she's still on mute. Oh, there we go.
Hi. I actually forget what my question was a few days ago, so I'll let you ask that one. But I just want to say this is quite incredible, all the work and the just the capacity, the opportunities for capacity building within our healthcare system, because there's something really unique about peers supporting, someone who understands really what it's about, what you're facing day to day at home, at work, balancing all those different priorities. So I think with the intensity of this last year and all of the social challenges in terms of the issues around racism, the pandemic, parenting, all of those things that you talked about, this is just quite an incredible opportunity to spread across the country. So thanks for sharing that, and we will do our best to also share the work on our website and with others. So thank you.
And we're delighted to really come to, we've been giving so many presentations across the country as well. We're delighted to not only share our program as it stands for ourselves, right? We're here and we're committed to helping others The training, depending on what different institutions need. Some people have asked us only for the training. They're good. They want to start a program. Others actually are looking to us to help them from ground up. How does one approach senior leadership, get their resources in place, and then ultimately, once the program is in place, how do we coach people through sustaining their program? So it's been an amazing and wonderful experience for us and our team. As I say, Laura is the key expert. She knows how to do this. She does those monthly rounding sessions or drop-in sessions. And we have learned so much about different departments that we would never have thought are front line or front of mind. When the culture changed so much because of COVID lockdown, simple things like not being able to share a meal with your peer, even if you might be at work, even if you are you have to be in the hospital and providing clinical practice in one of those specialties has really affected individuals. I won't, because this is being recorded, tell you which department, but that small change affected the culture of that department, and people really felt isolated. And it's not to say that we weren't all affected, but sometimes these things, when we are able to sit around in a very safe space, understand each other. Laura, do you have a comment?
No, I think just to reiterate what you said, that our check-ins with our faculties in every single department really brought a bit of a culture change in itself, in that departments became aware of the stresses of other departments as well. Because, you know, when there's stress, you kind of look at yourself and what's going on, and sometimes we don't look to other departments to understand their unique stresses. And it was interesting, two departments were actually able to link. They weren't departments that were particularly connected in the past for some events that they had created, and it really did create a nice culture within our university of looking out for each other.
Thank you. And Chris, you actually did bring up some of the the gist of the question you submitted, which is, what is the biggest challenge that you found in forming these groups?
In terms of the well-being leads, actually it wasn't difficult in getting the program started. So part of the challenge is, whoever's going to lead this, you need to have good trust and strong connections with your peers to start off with. And because I had been a chair chief for 10 years, I was chair of the medical advisory committee, I knew all the chiefs of the departments. And when we called upon them to help us start this program, most of us didn't even understand what exactly we were going to do. We knew in a framework that this is what we wanted to do, but some of it was based on a lot of trust to get the team started. And that is the first hurdle, because without people, we would have no program. Our fundamental core is based on our peers. And having built the program with 17, our number up there is probably underselling ourselves. We have about 50 peers now, peer well-being leads. And those well-being leads, in fact, have incentivized each other. We have people who are not technically a well-being lead making referrals now. And almost to the extent Laura and I discussed recently, I think we need to just bring this person on as a well-being lead, because they have become so engaged. And the culture change is amazing. It is palpable. So to give you an idea of what happened recently this week on, let me think, this is Friday, so probably Tuesday, day after what happened on Sunday. We had individuals reaching out to Laura, myself. How are we going to message this? Who's going to message first, respecting that there is a process. Once we gave them the go ahead and said, here is a bit of a template, a format, you reach out to your peers, just go ahead and do that. Leaders sent us back their messages, and they were so poignant, identifying that there was really a triple stress for our faculty. One, for those who really were frontline. Two, many of them knew the individuals. We are a small community, and either as friends or even family. And thirdly, those in the same faith, their community was really so distressed. And without the program, how would we have contacted so many people in such a short period of time? Because we have 900 faculty. So if you look at our school, and I see Barbara is there. Hi, Barbara. Barbara remembers back in the day when we had one assistant dean of faculty wellness and equity. One person could not have done this. I could not have done this back in January and March to help an entire faculty with one vice dean. Three of us can't do it. We have 50, probably 50 individuals, I think now. Medicine has expanded, 14 individuals, divisions. Surgery has expanded at least 10. Different departments have site individuals. So if you add them all up, it's a huge team. It's a huge team. So the first challenge really is to get your people, and then to keep your people and to keep them moving forward. And yes, people are tired. Wave 3, people are tired. So to get that data back, I know Laura has let me know that, but I think what we need to do is just to pause it. I'm not fussed about our data. I was at the beginning, because can you imagine, you start a program, you don't know if anybody will come. It's like you're going to have a open house. Remember back in the days where we could have open house parties, and then you don't know, Big Bang Theory had one open house and nobody showed up. Well, you start a program and you think, is anybody going to use this program? Is anybody going to come? And that would have been abject failure. So I had to wait. I waited 3 months before we gathered speed and gathered data. So, but we can reassure you that people will come once people know about the program and they feel safe. And I know Laura will say, not one person has said that this is a horrible program. At least we've not heard. And everybody that we've reached out to and had that conversation has said, thank you.
Thank you very much. Farine Dosa, the next question.
Thank you so much. This was an outstanding presentation. I'm absolutely delighted to hear about this program. And if you haven't published around your initiative yet, I imagine that will come, because it is such a groundbreaking type of initiative, certainly catalyzed by COVID, as you mentioned, and having this foundation, the people, as you mentioned, as being so key. And I guess my question is around the people. So, Andrea, you mentioned around leadership, buy-in, and being decanal leaders yourselves. They're obviously having that support at that level is so important. But you also mentioned that the wellbeing champions that were identified within the departments were volunteers. And I guess I wondered, how sustainable is that in the long run, or how easy would that be for other institutions to emulate, sort of when we realize that a part of burnout and well-being is that physicians have been expected to do this type of important work off the sides of their desks for so long, and not getting sort of protected time or support, in that way to really, devote their energy and expertise. So that was, one of the questions I had was around sustainability, and it also kind of sends a message to department members that this work is supported at the upper levels of leadership when funding is available to support that work. So be really interested in your comments around that.
So Laura can probably address how we already have gone through in some departments a new well-being lead and the sustainability of that. Do you want to take that question, Laura?
Yeah, I think in a couple of departments, it was only one or two. We did switch leads after the first wave. These check-in monthly were so important, because we were able to keep a finger on the pulse and really emphasize to leads, if you're getting tired, if this is not something you're finding fulfilling and energizing, let us know. You're always welcome back, but we don't want to be burning out our well-being leads. So those check-ins were really important, and we were able to have three leads total step away with open arms to come back when they're ready, and then put in some new leads in the department. But they did very, very meaningful work during the first wave, and then we're able to step away. So I think we do keep a finger on that pulse. As far as the second area, Andrea, I can have you speak to that.
Sorry, I've forgotten the question.
I
Could you
can tell you
repeat that? Oh, was that about the leaders? So in terms of getting the leaders to recognize the work that people do at Schulich, we have what we call academic role categories, and that's kind of different phenotypes where you're typed as either clinician, teacher, educator, researcher, scientist, and administrator. And within those categories, we do recognize that there is an element of, for a better word, service or administration. So this can be counted there. But on top of that, peer support is in its essence mentorship. It's sharing. And lo and behold, the Acuity Star, which is the program we use, we now have a section in there. So it's recognition, not necessarily payment. And it's also recognition by your leader. So to give an example, many of our chair chiefs have publicly expressed their own personal feelings and value to their faculty. That has gone so that's really resounded when you see these emails that are sent out, and even our dean has posted on his website, about individual chair chiefs that really embrace that. So you do need that sustainability. You do need your senior leaders to understand that this is important. And part of the those resources, undeniably, you do need also money. You do need some financial resources to make sure that you do have leaders. You can't do this on the side of your desk. You cannot launch a program based on the last thing you do at the end of your day, and it's now 7 p.m. So for those leading the program, you absolutely do need resources. But the essence of the well-being leads, though, they can't be paid. It's not to be confused with programs that are now taking off as a catalyst from the well-being leads. So several departments have now said, we want a complete wellness program for our department. That is something separate. A wellness program, you want to bring in some education, some activities, wellness development, resilience development. Those activities can have a designated funded leader. But the well-being peer supporter is, in essence, must remain as a volunteer. So our program actually has served to get several departments enthusiastic and beyond enthusiastic, but have embraced complete programs. Laura came from the Department of Emergency Medicine, and hers was one of the few programs that actually had a departmental wellness program. So we didn't happen to have to find Laura. This was not a happenstance that Laura is the new Assistant Dean of Faculty Wellbeing, because she came from a department that this has been a passion. She developed it for her department. She had the experience. So one of the key attributes of any program is you do have to have people and leaders who are committed to doing this. And you will laugh. I will share with you that at the beginning, I certainly had this on my plan my 3-year plan as a new vice dean, but it was like year 2, year 3. It got expedited to 3 months. 3 months into the role, you're doing this. Does
Thank you
that
very much.
answer your question?
Yeah, that's excellent. Thank you so much. Very
You're
helpful.
welcome.
Thank you very much. We have time for one more question from Dr. Barbara Lent.
Hi, everyone.
Hi, Barbara.
It's actually very exciting for me to hear about all the work that you've done, and it's amazing to me, having sort of had an interest in similar things way back when there was less structure and less institutional support on every level for pursuing these kinds of things. So partly, I had sent a question to the Federation ahead of time before your talk, and I apologize for joining late. And my question was, what has been the response of clinical faculty, and and in part, how did you deal with any resistance? So even from what I've heard, it sounds like you've had a terrific response. So if you want to expand, but I do want to there's a couple of things that I heard that I just think are terrific. And one is, clearly you facilitated a kind of culture change, a big institution culture change that says these kinds of issues are important and we all have a responsibility as individuals and as colleagues and as departments to help address it, so people just don't feel overwhelmed and like they're always running as fast as they can and not getting where they want to be. So that's terrific. And the other thing that I was really impressed hearing you say out loud was that it was really important to value this work as part of people's job description in whatever you called them, phenotypes, but that this kind of peer support is given value, because it's not that none of it happened in the past, but it often was not valued, not appreciated. It was done on top of everything else. And the people that sort of inherently got it and knew that it was important did it on top of all their other things. So even without getting money, just to say, because there's lots of parts of the work that we do as academic docs where you don't directly get a dollar value for that contribution, but to say this is an important way that you contribute to how the faculty functions is a terrific message. So congrats.
Thank you, Barbara. Thank you, Barbara. We are, to answer the question about publishing, and that's why we don't have, we do have data, but we're not showing the data because we're in the process of publishing. And so that's one reason. We have helped over 200 individuals have had over 200 encounters. I guess that's more accurate. And it has been incredibly well received, Barbara. It's been amazing. And the level of engagement and the automatic culture change, it's very hard to measure culture. All I can say is with the most recent event, the automatic switch now is we need to contact faculty well-being. Like, do they know? Okay, well, yes, we do know. And then what are we going to do and how are we going to guide our team going forward? So Laura and I know this, and so we it's so rapid and so much appreciated. And then we see we get to reap the benefits of that, because as the leads send out the messages, we know that that's what they're doing, and they're providing the support that they were designed to do. So that's how we get our feedback. How many people respond and how they're immediately during the crisis. And we experienced that in real time this week. Laura, any comments? Laura, I don't think you've met
Yeah,
Barbara Lent. Barbara Lent is Barbara, you were the past vice dean.
Oh,
I don't know.
10 years ago, my role was associate dean of equity and gender issues, and faculty health was sort of an add-on. But at
She
that
was me
point,
10 years ago. And I've known Barbara for 20 years.
It was much earlier in the continuum of this work is the important thing. There was a lot of skepticism about how why do we as docs have to take these issues seriously? And clearly, the faculties and the broader profession is at a different place with respect to those issues. And it's partly because of the really good work that you guys are doing. So congrats.
Thank you.
There's another question from Farine. It says, so is there a new dedicated wellbeing leadership office similar to the Stanford model of a chief wellness officer? So I can explain our structure here in that there is not a chief wellness officer at LHSC or St. Joe's on the hospital side, but certainly on the university side, we are nestled within clinical faculty affairs. So Andrea is the vice dean of that office. In my role, I am responsible for faculty wellbeing, harassment, intimidation, and faculty mentorship, and that's what my my role responsibilities are. We have a third member of our team who's excellent. Dr. Bill McCauley comes as an adult emerge physician and with lots of experience at the CPSO, and his role is Assistant Dean of Professional Affairs. That's a brand new role that he does to support our team.
Amazing.
So
Thank
we're
you so
still
much.
quite a small team, but we have enough resources now. We could be larger, but we can always be larger.
Thank you very much. And I'm going to call again on Dr. Kristen Petrocelli, our national president.
Thank you so much for just an outstanding sharing of information and all of the work and efforts that have gone into this. And we really can see how it will be exponential, because what we give to our colleagues will then be able to inspire their capacity to keep going and to give to all of our communities. So I think this work really is incredible. And we're really honored to have you present on behalf of the Federation today. So thank you so much.
Thank you for the invitation. Okay, Barbara, can you stay on at the end? Michael, would you mind if we network with Barbara? Because we haven't seen her in a while.
Sure, just I'm going to say.
Oh, when you jump off, will we all disappear? Like sometimes that happens.
When I jump off, you disappear.
Oh, we do. Okay.
Yeah.
All right. Barbara, we'll get together at a different time then. Thank you.
I just want to thank everyone for joining us today. This session has been recorded and will be up on our website. For those of you who are viewing on the website, feel free while you're here to click on either membership and either take out a membership or renew your current existing one, or click that donate button and donate to our continued programs such as this, and or to the Medical Women of Canada Foundation to support the of which Dr. Lum is on the board of, to support the Maud Abbott Scholarship Foundation and the Maud Abbott Research Foundation. And the website is fmwc.ca. I hope you found this session as informative as we did, and look forward to joining you in future sessions. Thank you and have a good day.
Thank you.